UK, so that's fantastic. And she's here today. We're not giving her one job, we decided to give her 2 jobs. If we get Irene here, we want us to have 2 jobs. So her first and main thing today is going to be talking about her international collaboration on management of breathlessness. And then she's also going to just mention about some new opportunities with the ARC coming through. So I'll stop sharing my slide, Irene, and let you take the floor. So thank you, Irene.
Yeah, thank you very much, Amy, and welcome to everybody. It's great to be here. Can everybody hear me all right? That's an important first test. I don't want to talk and not. Okay, let me try also sharing my screen. And of course, as life goes, you try this beforehand and it works. And so let's see if it works now. Can people see that now going on to, hopefully in a moment, going on to slideshow? It's not quite on slideshow yet. Try again. There we go. Is that on slideshow for everybody?
Yeah, that's there, Irene. Thank you.
Fantastic, thank you. All right, so I'm actually going to mention the Applied Research Collaborative first. So these are, I want to make everybody on this call aware of this, so that you can see if you can work within your local communities to get involved in your NIHR Applied Research Collaboratives. So these are collaboratives. They currently exist. I've shown you a map on the left-hand side of the slide where all the applied research collaboratives are. But for all of you who do applied research, these are currently in existence, but there is a new call. I've provided the links on the slide for the call, so you can see a bit more information, but you can also Google it. But there's a new call out, which is closing in January, and it's an opportunity for all of the existing ARCs to rethink their themes. And so there's an opportunity, if you're not involved in your local ARC, to try and get involved in terms of palliative care. So do look out for that if you're interested, and approach your local ARC to get involved. If any of you are in South London and want to approach me or others, please do. This is a little bit more about the ARCs, and this is their job. And most of the resources, and they're not huge, are for kind of glue to help people come together, and also to do knowledge mobilization from the work. But you can see here on the left-hand side the role of the ARCs, and on the right-hand side you can see the priority areas. So these are set by the National Institutes for Health Research, NIHR, and you can see that there's some that are relevant to palliative care. It's not mentioned, but you can see some of the conditions that are relevant to us, the integration between mental and physical health relevant to us, multiple long-term conditions relevant to us, services in the community relevant to us, as well as other areas that you might spot in this that are relevant to you. So please do think about approaching your local groups. I'm going to move us on now to my presentation. Hopefully people can see this about mirtazapine. I think we will have questions or opportunities for questions later on at the end, and possibly between the talks. So please hold on to your questions until then. So I'm going to describe to you now some work that we have conducted, supported by the European Union's Horizon 2020 Research and Innovation Programme, but also with some additional support, as you can see there, on behalf of a big team of people called the Better Be Consortium. And here I'm going to focus primarily on the results of the trial that we've recently published in Lancet Respiratory Medicine. And on the right-hand side, you can see the QR code that takes you to our website. So the Better Be program had a great opportunity for early career researchers to be involved, and you can see a whole group of them there across the different countries. We worked on breathlessness, and this audience, I think, knows how important breathlessness is. It's a frequent, distressing symptom. We don't have much in our therapeutic armamentarium to deal with it. It's common in many conditions. It's a frequent cause of hospital admissions. but our pharmacological management is limited. And so people had got interested in using or trying to repurpose medicines for it, in particular, trying to repurpose the medicine mirtazapine, which people had already tried looking at antidepressants for pain. So the same thought was that, can we repurpose something for breathlessness? And obviously, mirtazapine might be valuable because serotonin in the brain is involved in the production of breathlessness. And if you go into it a little bit more, you can see that if you think of the model of breathlessness as the balance between load and capacity, and what you're trying to do really is influence the way in which people perceive breathlessness in the brain, because that's actually quite an important aspect. And you can see I've lit up just on the top left some of the areas of the brain that are involved in breathlessness. What we're hoping to try and do is to influence that. And actually, when we did a survey across Europe of what clinicians were using, then actually we found that respiratory and palliative care clinicians, about between 11 and 19%, were actually using antidepressants. A number of people had done case studies suggesting that it might be helpful, and we did a feasibility study to show that we were able to do a randomized controlled trial. So the Better-Be trial, which has been published in Lancet Respiratory Medicine, and you've got a QR code there on the right-hand side, involved 16 centers in 7 countries, focusing on people with chronic obstructive pulmonary disease and interstitial lung disease, testing mirtazapine escalating up for 56 days versus placebo of maxed appearance, and the primary outcome was worst breathlessness over the past 24 hours, but we used a range of secondary outcomes, and this was informed by our feasibility study. We registered the trial, and we used a modified intention to treat multivariable, multi-level, repeated level model for the analysis. Now, it's not easy, as I'm sure you all know, to run a clinical trial, even in the best of circumstances, in people who are very sick with palliative care. It's even more difficult to run it during Brexit in an international study involving multiple European countries, where Brexit had impact on what we could do in terms of sponsorship and co-sponsorship. We planned for some of that, but many things, and then a worldwide pandemic. So I'm particularly pleased that the team actually managed to complete the study and that we were able to recruit. We recruited 225 people, randomly assigned them to either the mirtazapine or the placebo group. The study was blinded, and we didn't actually know the groups until we'd fully finished the analysis of the results and we had decided what the findings meant in either side. You can see that the numbers there were reasonable. There was a little bit of attrition, but not too much. But you can also see on the right-hand side that there was quite a lot of individuals screened, and quite a number screened out because they were already taking antidepressants or a serotonin active medicine. We included in the study interviews with informal carers, and we also interviewed or we conducted qualitative interviews with participants in 2 centers. So let's take a look at the sort of people we included in the study. So you can see that we had a population of roughly the age that we would expect, with the same clinical characteristics that you would expect. A moderate degree of anxiety and depression, not that much, about 20% on HADS above the normal threshold for either anxiety or depression. Small percentage were already on opioids, reasonable mix between what was called the MMRC grade, which is a grade of breathlessness. And grade 3 means that you can't walk more than 100 meters. And grade 4 means you're basically completely immobile in a chair, can't move around very much, or you can't even dress yourself. Very high level of comorbidities in this group, as you'd expect. One of the important elements of the trial to note, though, is that in the attrition side, we saw greater level of attrition that is lost to the study in the mirtazapine group. And you can see that by day 56.
That's a big wake-up call for him. He went, yeah.
Sorry, Irene, we can't hear you at the moment. Can you just unmute? Thanks.
Oh, sorry. Yeah, you muted everybody as somebody who spoke.
Sorry.
And me too. Let me just go back. So thank you for flagging that. So you can see that there was some attrition in the study, and in particular, it was slightly higher. Look, for example, on the bottom right-hand side at day 56 in the mirtazapine group. And we used the MoreCare categorization for attrition, which can be found on the Equator network. So what were the results? So, as I said, blinding continued until after we had agreed interpretation of the results, partly also because they were quite close between the study arms and we wanted to be clear. But what you can see is that actually there was no difference in the primary outcome. That's the top graph on the left-hand side called A, in the mean worst breathlessness scores adjusted for baseline score by treatment arm and time point. We did a sensitivity analysis allowing for the fact that we had got greater attrition in one of the study arms. As you will recall, it was the mirtazapine arm, just to see if that made a difference, modeling conservatively that the attrition group would be worse. And what you can see there is that actually the mirtazapine group got slightly worse, even more slightly worse than the placebo group, but not significantly different. And when you looked at all of the secondary outcomes, you saw no difference for the outcomes that existed. I've given you a list there, but if you want to see the details, they're all in the supplementary appendix of the paper. But when we turn to adverse reactions, we see that the mirtazapine arm had higher numbers of people with the milder form of adverse reactions, but they were there. Now you can see the numbers there, 64% in the mirtazapine arm, 40% in the placebo arm, although serious adverse events was not particularly different between the two groups. And you can also see on the right-hand side, as you look at the graph, that the mirtazapine group had slightly higher acute hospital nights, outpatient visits, and more hours of family care. We've also conducted, and you've probably seen this, we took the results pretty quickly, and thanks to the editors who all worked with us well over this, into palliative medicine, into a guideline review, which looks at the different medicines that you can use for severe chronic breathlessness. You've got the QR code headed up by one of the team, Stefan Simon, and that's been published in Palliative Medicine if you want the guides to this. So the take-home messages from Better Be are that we can conclude with 95% confidence that mirtazapine doses of 15 to 45 milligrams over 56 per day over 56 days does not improve severe breathlessness in people with COPD or ILD. And further, it might cause adverse reactions and increase care use. And on that basis, it's not recommended to alleviate severe breathlessness. Now, I should say that the study was slightly underpowered, but as you can see from both the sensitivity analysis and the range of confidence intervals, I think we can be sure that even if we had achieved our original target sample size, we would not have changed this result. This means that there's still an urgent need for rigorous, pragmatic clinical trials in assessing different treatment. And we should avoid, if possible, recommending untested treatments outside of a rigorous evaluation framework in palliative care on the premise of do no harm. And I would also say that you might want to take a look at the Better Be website. I'll give you the link again in a minute. To help you download, you can download patient and clinician and policy guidance, and hopefully one of my colleagues will stick the Better Be website in the chat as well for you. I'd just like to thank all the many people who were involved in this study, the patients and carers, our public involvement group who worked with us, our different independent oversight group, and the different partners and consortium and places where we collected data. So that's the main conclusions of the trial. And I'm now just going to hand over to Dr. Emma Granger, who was the team at Lancet Respiratory Medicine were excellent to work with. And she's just going to come along and say a little bit about why they selected the paper and the issues from the broader perspective of Lancet Respiratory Medicine. So over to Emma.
Thank you so much, Professor Higginson, for the kind introduction and also the invitation to participate in this really important webinar today. So as you heard from Professor Higginson, the Better Be trial was published in the Lancet Respiratory Medicine, and we timed the publication to an ERS alert session in September. And I just wanted to really highlight today, you can see on the slide, Irene has already gone through a number of these points, but we selected the paper for external peer review. We only select in the region of about 20% of papers to go out for external peer review. So severe breathlessness, as you heard, is it's a major problem, and it's also a global problem. And this was top level evidence, so it's a well-designed and executed phase 3 randomized controlled trial. And again, as you heard from Irene, there already is substantial off-label use of mirtazapine. So for the patient group in this trial, it was between 11% and 19%. And growing interest based on very limited evidence, again, as you heard, mostly case report evidence, although there was a prior feasibility study. So the study had implications for future care and could lead to a change in clinical practice. And again, one of the very key points that made us send this paper out for review was there was increased healthcare use in the intervention arm, and also importantly increased adverse reactions. So this is classified, as editors we classify this as an important negative trial in an area of unmet need. And I would flag as well that the paper is free to access, and there's also an associated link comment that discusses some of the issues that were raised during the peer review process. So thank you very much, Irene, for sending this terrific work our way. And we hope it really has an impact in terms of de-escalating treatment. First, do no harm. So thank you again, and back over to Irene.
And thank you, Emma, and back to Amy.
Mm-hmm. So thank you both for that fantastic trial, Irene, and I think Emma summarised it perfectly about why it's so important. So what we're going to do, we had a suggestion if there's any burning questions, but it looks like there isn't at the moment. We're going to park the questions because we've got a fantastic panel. So we've started with a doctor, we're going to have a physiotherapist and then a nurse, so really showing the multidisciplinary work of breathlessness. So I think if we might as well, I think Matt has already agreed, let's crack on with the next presentation, and then we'll have plenty of time at the end for questions. So I'm delighted to welcome Matt, who's a professor in health services research and is a physiotherapist by training. He also has leadership roles within the ARC, not only within palliative care, but across the whole ARC in South London. So that's a really fantastic leadership role there as well, to link in with the ARC and this webinar. So over to you, Matt.
Thanks very much, Amy. Hopefully people can hear, stop me if not. So
I can hear you perfectly, Matt, and the slides are perfect, so thank you.
Brilliant. I had the title suggested of what works and what doesn't for non-pharmacological treatments for breathlessness. And the conclusion, and highlighted also in the practice guidance that Irene flagged to everyone, is that people should really have a firm basis of understanding breathlessness, of treating any reversible causes, and of offering or considering any medicines on a background of non-pharmacological treatments. And I also just want to consider initially under this title of what works means, and what works can be measured in many different ways. And one of the difficulties of progressing care for people with breathlessness is understanding the different ways the symptom presents and the different ways the symptom affects people. So this circular diagram is coming from the American Thoracic Society. It's an attempt of putting different measures and therefore different ways things can be understood to have worked for breathlessness. So we have like this sensory experience circle at the top here, which may be someone's rating of breathlessness severity or intensity. We might use, for example, a numerical rating scale to do that. In the bottom, we've got the affective distress that's related to that breathlessness. That might be very immediate, someone feeling particularly distressed, or it may be reflective and understanding how emotive and harmful that breathlessness has been over a period of time. And then finally, we have the symptom impact or burden. And that might be something like the Modified Medical Research Council scale, which says you're restricted because of your breathlessness. But it also might be someone's performance in, for example, a walking test or a measure of how their health status or quality of life included has been affected by their breathlessness. And for different people, success or what works may be a combination or individual aspects of each of these buckets of measures and ways which we can understand breathlessness. In a similar way, many people will be aware, but there's a brilliant tool coming from the group in Cambridge, pioneered by Sarah Booth. This model is understanding breathlessness to the individual patient. And for some people, they can have these breathing cycles. For example, people who have a very kind of fast and high rate of breathing and some hyperinflation, which causes and builds up their breathlessness. For other people, there's this thinking cycle where they perhaps have certain fears or anxieties about their breathlessness and go into a state of concern or distress or panic. And for other people, their breathlessness means that they avoid activities and they take on help and become dependent in the everyday activities of their everyday living. And this tool is really useful to help us and to help our patients and families that we serve to understand breathlessness, but also to start to navigate how we might offer appropriate non-pharmacological treatments. And depending on which of those cycles is predominant, we may select a treatment to offer in the first instance to get a kind of quick win with that patient. For example, a breathing technique may help that person with a breathing cycle, focusing on education and psychological support for someone with a thinking cycle, and then perhaps focusing on exercise or pacing techniques for someone who's predominantly presenting with that functioning cycle. And there'll be things which can be added and introduced further on, but the service are using this to try and understand where that first quick win and where the patient buy-in can be got at a very early stage, or what can be offered in a single session of intervention. So the next slides I'll kind of rattle through, but I want to reassure you that there's a strong evidence base for each of these component techniques coming from crossover trials or coming from randomized controlled trials. So here for breathing techniques, focusing on pursed lip breathing, for example, or timed breathing, where you'd ask someone to focus on a window or a door and they're breathing out on the long side of that shape to avoid hyperinflation. Or diaphragmatic breathing, which is using the diaphragm, focusing on the abdomen coming in and out, and avoiding use of these accessory muscles around the neck, which we should not be using for everyday breathing. And again, throughout these trials, the breathlessness intensity is reduced. Their walking performance, so the impact of breathlessness, is improved, and their quality of life, a result of the burden of breathlessness, is also improved. So there's multiple randomized controlled trials which are underpinning the evidence for use of breathing techniques. Similarly, a handheld fan people will use as a very simple and practical treatment for many settings. There are different ways that the fan has been thought to understood. It may include the cooling of the face and an airflow to the face. It may provide a distraction or a way that the patient feels more in control of their breathing. And many people discover fans for themselves. And of those that are using a fan, many people say that it helps them to become more physically active. And again, from randomized controlled trials and very nicely controlled designs, we can see improvements, that's to say reductions in breathlessness severity using a fan for people who are breathless at rest, for people who have just used a fan, for example, during or after a walking test, and also in those oxygen trials where the airflow control arm without the use of oxygen is also shown to reduce breathlessness sensation. Energy conservation techniques, these are things physiotherapists, occupational therapists, and everyone else can offer. These are very simple pieces of advice. The graph on the left is a stair climbing intervention, and again in a crossover randomized design, they ask people who are particularly breathless to stop on every third step and to ensure that they're not having an escalation of their breathlessness, to give a focused period, I think 5 seconds of rest at that time. And compared to when people were allowed to go off and use their own strategy, there was a reduction with this strategy in the use of ventilation. There was a lower energy cost, less breathlessness, and at the end of the day, people were climbing the stairs in a very similar time to if they were perhaps going off very soon and having to kind of wait and stop for some time in the middle of that staircase. And that's been shown across a range of daily activities. And the use of these very simple and practical techniques, again, has an evidence-based underpinning. The same is true for the use of a relator or a walking aid, and we might be inclined to think about these as ways to reduce falls. We might think about these things for people who are particularly unsteady. But for people who are breathless, use of an aid and use of a frame to support their breathing can reduce the ventilation, increase the efficiency of their walking and ambulation, and that can allow people to become more physically active, to participate in social activities as an example, or to stay more independent and to be able to support their daily living. And again, there's a modest but a well-designed evidence base to support these compared to using a stick or without a mobility aid. People are able to walk further and report less breathlessness at the same time. And then finally, exercise and physical activity. These terms cover a whole range of modalities and types of activity. On the left, we have pulmonary rehabilitation, which is an exercise training class. People should be encouraged to learn about and consider rehabilitation services where they exist. Because of the dual role of the upper limb muscles in stabilizing the chest and performing activities, if those are targeted with exercise training, then people reduce their breathlessness and can improve the performance of tasks that are demanding or using upper limb and arm activities. And then on the right hand side, things like meditative movement, yoga, tai chi, and also muscle stimulation, where a current is passed through the muscle tissues to offer a very low intensity, non-provocative form of exercise training. And that has limited effect on breathlessness, the sensation of breathlessness, but each of these modalities can improve different markers of functional performance. So they're allowing breathless people to access exercise and to improve their function as a result of that. And then in the last few minutes, I'll just talk about breathlessness services. And if you look between the lines, and if you look carefully at the composition of these services, some examples on the left, they're using predominantly a non-drug approach, and they're using these treatments in different combinations, and they're picking the right treatments for the right people and at the right time. They're fairly low cost and light services. They may involve maybe, for example, 2 outpatient visits and a home visit, or 2 to 3 visits in the community. And they're very multi-professional. They're not as much led by medicine as they are nursing, physiotherapy and occupational therapy. And they have a strong palliative care ethos in that they focus on the person before their disease, and they're thinking about how to help someone live with their breathlessness rather than trying to take it away. Again, there's a fairly consistent and growing evidence base for these services relating to the emotional and affective aspects of breathlessness. People have reduced distress and feel better mastery or more in control of their breathlessness. And there's a fairly consistent signal also in the affective dimensions of anxiety and depressive type symptoms. There's a great recent review in European Respiratory Review that does a great job of looking at any safety concerns or adverse events from these services, and they're very few, mild and far between. And there's also a growing economic evidence base for these services. When it's measured, they're small, but more often than not, there's gains in quality adjusted life years where the study has taken that into account. And then to finish, there are also some really excellent qualitative studies understanding when people access these services, how they affect their changes in health, and what are the sorts of characteristics which are valued. And people particularly emphasize these very simple and practical tools. And as we'll hear about in a moment, the involvement of family and caregivers is particularly valued by patients and families alike. So my take-home message is that breathlessness is common and distressing, we've heard. There are many evidence-based treatments, but these seem to be non-pharmacological, and there are many things which people can try and select. And for me, as a physiotherapist, I'm passionate about rehabilitation. Breathlessness is one of these symptoms that really highlights the relevance of thinking in a rehabilitative way, including within palliative care services. Thank you.
So thank you very much, Matt. That was a really complimentary presentation there. So that's why, and I'm going to move now on to Morag and the carers, but thank you very much there, Matt. Just if there's any burning questions, but I think there isn't, I think we might just keep moving on, because I think as you're realising, we're going to be able to have that really helpful discussion at the end when we have all the presentations together. But do now start thinking about your questions. I've been purposely very strict with the panel and made them talk for only a bit of time, so we'd have that time for discussion. So please start thinking of your questions. You can either put them in the chat or you can put your hand up at the end. So I'm delighted now to welcome Morag. So Morag is a nurse by background, but been a health service researcher for over 30 years. And she also has leadership role within the ARC, leading on the palliative care and end-of-life care in the east of England, and also within the National Palliative and End-of-Life ARC. Her real interest is in carers, and so I'm delighted to welcome Morag.
Lovely. Thank you, Amy. Can somebody confirm that you can hear me?
And I can hear you, and your slides are perfect. Thank you.
Super. Thank you so much. And it was great in the last two presentations to see unpaid family carers being included. So thank you for that, everybody. So just to check that we're all on the same page in terms of who carers are, the definition we use a lot is the one that NICE uses, of lay people in a close supportive role who share the honest experience of the patient and who undertake vital care work and emotion management. And these carers are often hidden in the background or completely out of sight, as in the picture in the middle. So in terms of their role in supporting someone with breathlessness, well, this places considerable burden on carers. They often have multiple roles, including requiring overnight vigilance. And this can lead to restricted and isolated lives for the carers as well as the patients. Carers are largely unsupported in breathlessness. They can lack knowledge, confidence, and strategies in how to support the person with breathlessness. This can lead to them feeling helpless and powerless. It can cause anxiety, which then leads to crises. And that carer fear and anxiety drives demand for emergency healthcare, which is sometimes unwarranted and sometimes actually unhelpful. So there's a lack of evidence-based education interventions to support carers of people with breathlessness, and symptom-focused breath interventions are particularly rare. Systematic reviews have found no carer educational interventions for chronic respiratory disease or for breathlessness specifically, but there is a new ERS task force underway on carers of adults with chronic respiratory disease. So it's not specifically on breathlessness, but it will obviously include that, and it's being led by Alda Marquez and Daisy Janssen. So please look out for that. So because of this dearth of evidence and resources, we developed the Learning About Breathlessness study program to develop a resource to help support unpaid family carers. And at the beginning of this program, we first needed to answer two questions. What does carers want and need to learn about to help them to support someone with breathlessness, and how do they want to learn? So to address this, we gathered the views of carers and patients living with breathlessness due to COPD or cancer as the most common causes of breathlessness and advanced disease, and the clinicians who support them. And what we found was that carers wanted and needed to learn about supporting someone with breathlessness, and clinicians wanted to help carers learn. We also identified 6 key topics that carers needed to learn about. wide variation in how they wanted to learn, and then we came up with a means of meeting those varying learning preferences that I'm going to show you. So the 6 key topics they needed to learn about were understanding breathlessness, anxiety, panic and breathlessness, managing infections, keeping active, living positively, and what to expect in the future. In terms of how they wanted to learn, well, we went into this program thinking that we were going to be developing the world's best leaflet, but actually, particularly for carers of patients with cancer, there was leaflet overload. They were interested in face-to-face learning, either one-to-one or in a group. They were also interested in video or web-based learning, but they're almost unanimous in wanting that learning to come from clinical experts and from peer carer experience. They were keen on visual information in the form of pictures and films, but we were surprised to learn that they actually wanted to learn with the patient, although this wasn't true of every topic. So that last topic about knowing what to expect in the future, they preferred to learn about on their own. They wanted personalised or individualised learning, and they didn't expect the resource we developed to be able to answer all of their questions. They were happy to be signposted to other resources. But I think you can see from this that their preferences for learning varied widely, so we had to find a mechanism to meet all of these preferences. So what we did was developed a web-based educational resource that could be accessed in 4 ways. So it can be self-accessed or prescribed by clinicians. It could be looked at in peer-led support groups. It can be looked at in clinician-led groups and also in clinician one-to-ones. The website needed to cover those 6 topics, have a menu so that it can be individualized, have those written words and pictures, include short film clips from experts and peer carers, include downloadable leaflets for those who are unable or prefer not to look at material online. It needed to have links to other resources to enable that signposting, but really importantly, it needed to be badged or endorsed so that carers had confidence in using it and clinicians had confidence in referring them to it. So in developing the website, we work with both current and bereaved carers, patients, clinical experts, and web design experts. So that's both in the psychology of web design, but also in the mechanics of it. So before I share the website with you, feedback from carers is that you can only benefit from it. It's important for people who are looking after their partner or a wife or an elderly family member to understand what to do and how to help as best as possible, and it's invaluable for that. It does offer something which others don't, which is that it's a carer-focused website. It looks more, I suppose, at the social and relational aspects of being in this situation, which is useful. An endorsement from clinicians, a cancer clinician said it feels very professional. It makes you feel this is a safe, professional website that I can trust. And from COPD, I like the topics. It's not just managing the symptom, but the stress, panic, keeping active, and living a positive life. So this is the website. It's called Supporting Someone with Breathlessness. I've given you the link there and the QR code, which I'll put up again at the end. But you'll see that it starts with a welcoming video which is a peer carer and expert clinician talking about the importance of supporting carers of people with breathlessness. If you scroll down the homepage, it then takes you to 6 topics. You'll see underneath each one there's a different button, one for cancer and one for COPD. And importantly, you'll see that those 6 topics map back to those 6 areas that carers told us they needed and wanted to learn about. It also maps back to how carers wanted to learn. So it has a menu, it has written words and pictures, it has those short film clips, it has the downloadable leaflets, links to other resources, and is badged and endorsed. And it's been deliberately designed so that it can be accessed in those 4 ways I told you about earlier. So if we clicked on one topic, so stress, panic and breathlessness on the COPD button, it takes you to a page and you'll see that each topic has words, pictures and films. You can then click on subtopics, which takes you then to more detailed information on that subtopic. Each topic includes film clips from both peer carers and from clinical experts, as well as film clips of patients and carers demonstrating strategies and discussing sometimes difficult topics. There's a useful things page where those downloadable leaflets are, and it also has those links to other sites. We have promotional materials for the website, and these we've developed because carers and patients suggested them, that promotional cards and mock prescription pads would be helpful for clinicians to use. And you can download those from the website or contact me because we've just restocked some new hard copy ones as well. We've had national and international endorsement of the website from the BLF, the British Heart Foundation, the Royal College of GPs, the QNI, and from the NHS website for shortness of breath. There's a link to the resource at the bottom of that page. And the material's also been adapted for Australia and New Zealand. So just quickly to acknowledge the programme funders, there will be Cancer Care and the NIHR. Everybody who helped to make this work possible, and the enormous team that were behind producing this. Thank you very much.
So thank you, Morag. I think you've generated lots of interest in the chat, and I think we're going to have to just say to people, everyone wants to get on that website, just please wait another 10 minutes till the end of the presentation to get on there, because I think everyone really wants to get on. It looks fantastic resource there. So we will be circulating the recording and all the presentations, and the links are in the chat there, because I think people just want to get on and use all this fantastic information we've got there. So as I say, that we're given plenty of time for discussion. We're using this format so we can make it a little bit more open, so you can either put your questions in the chat, or actually you can just put your hand up. This is an informal group, and ask questions. So don't be shy. This is your chance, or put a comment. You know, it doesn't necessarily. I'm not going to be strict in terms of it has to be a question. If you want to put a comment or something that you found useful. So just while you're having a chance to warm up, I think I'll probably just give my reflections. I think I use breathlessness as an example for the medical students, and I think, Matt, you mentioned that it sort of is this, it incorporates the whole philosophy of palliative care, I think, in one symptom. It's so important, and that multidimensional approach. And the way our timetabling is that I do the first half of the year in August, and I've got the next group in a couple of weeks' time. So it's fantastic to actually reflect that I'm going to be updating my slides to the medical students over just a few months. So this idea that we're not doing research in palliative care, that we're not progressing the field, and we're not thinking, you know, we're not doing that, is certainly not there. So open out to questions or discussion, or I will ask the first question. If there's, I can't see anything in the chat yet. If anyone else can see anything, let me know. Or as I say, pop your hand up. So I'll ask the first question while people are warming up, for people like to warm up a bit. So Irene, it's the question to you. I just wanted to ask about your choice of primary outcome measure. I'm sure there was a lot of debate and discussion about that within it's such a key thing, isn't it? So just give you a chance to reflect on that, and on why you chose what you did, and what the discussions were there.
Yeah, thank you. And also, one of the reasons why I'm really pleased to have done this presentation all together with all three is that, in a way, this trial is saying, well, this drug doesn't work. So then what do you do? And the answer is that the non-pharmacological treatments is what you do. And I'll pop in the chat some of the resources that we've developed from our website for the things that Matt explained, that we put out at the side, or perhaps one of my colleagues will pop that in. And the choice of primary outcome is not an easy one, because it's a complex symptom. So we had done quite a bit of work beforehand trying to think of what the models of breathlessness were and how it was affected. And it was based on that we basically chose the outcome of worst breathlessness. That said, sorry, my dog's barking in the background, and I hope you can't hear him. Some people say, well, should it be mobility? We chose worst breathlessness rather than average breathlessness, because people take exercise to the degree at which they are, which they can breathe. So that's why we chose that outcome. It's debatable. If we'd chosen another one, I don't think we would have found a different outcome. In other studies, for example, the trial we did of the breathlessness support service, we chose breathlessness mastery because that seemed closest to what we were trying to achieve with the service. And that was how much poor quality of life influenced breathlessness. Yeah.
Thank you, Irene. That's really helpful. So I'll now invite, so I can't see all the names, Angela Mullock, sorry if I pronounced that incorrectly, to unmute and ask their question.
Hi, I'm Anjali. I'm medical director at an adult hospice in Bristol. I had a question around if the evidence is behind the sort of non-drug models, I guess the sort of multi-professional interventions. I was just wondering presumably there's a million different models, and what's the role of kind of hospice in that? So we're just exploring how we can have services that are more appropriate and fit for purpose for patients with non-cancer conditions, including patients with COPD or heart failure. So where does this all sit, and are there any good models that are going sort of in partnership with hospices and the NHS? Yeah.
Thank you. That's a really key question. So I might ask Matt to start, and then the rest of the panel have anything to add in. I think that a lot of people will be wrestling with that question.
Yeah, it's a great question. I don't think there's like a right and a wrong answer, and probably like a range of models that suit your local context will be most appropriate. I know that sounds a bit sort of middling, but some examples, I know hospices that do a combined fatigue and breathlessness group, and they use that Cambridge model of breathing, thinking, functioning, have 3 sessions and a rolling group like they would do in pulmonary rehab. So you're not thinking of one cohort for 3 weeks, you're having a rolling changing group of people that join a weekly session 3 times to cover those aspects. There are other models in Cambridge where it's very community based and people are going to people's homes. I think one of the important things is that a lot of people talk about breathlessness being invisible, and of course those people who are most breathless aren't able to leave their home without a lot of support, and they're not seen in society. So for some care provision, going into the home will be really valued and important. And then I always use rehabilitation instead of physiotherapy, and all of those interventions can and should be done by any health and care professional, and their resources, and they're not requiring a prescription, they're not requiring a lot of profession specific expertise. So I wouldn't wait to have a physio and an OT and a nurse doing your service. I certainly wouldn't mandate that it needs a medic to offer a multidisciplinary team. And we haven't looked, but there's a lot of consistent messaging, and the things that are valued come from kind of the individual components, rather than actually in the qualitative literature, no one is really saying what was great about this is every profession saw me at the same time. I think that's part of some services, but it's not what people noticed, and I don't believe it's what improved the clinical outcomes a lot. So I would say don't be too cautious that you have to do a gold standard service.
I think that's really helpful. That's a very practical answer, I think. Anjali, is there any other comments? So you're happy with that, or any other comments from the rest of the panel?
I think that's great. And as a hospice, it's kind of how do we link in with other services that are already doing stuff, so that we're not sort of doing things in silos. But thank you.
Could I just add that we actually did some work to ask patients what they wanted most, and did a discrete choice experiment where almost like you use menu cards and ask people, would you prefer that to that, that to that? And I've just posted the link to that in the chat. But essentially what people wanted is they were happy to go somewhere to get it, or they were happy to have it in their homes. They didn't actually want to go to GP surgeries to get it, interestingly. They either wanted to see somebody who was more expert in breathlessness, and they wanted a holistic review, and they wanted a comprehensive treatment approach. So actually they wanted to see several different, or be cared for by several different professionals, not just one. But I'll put the details in the chat.
Yeah, I think we're going to have lots of reading after this, and the Morag coming in as well.
So just to sort of add to what Matthew and Irene were saying, I work with Sarah Booth on the randomised controlled trials of the Cambridge Breathlessness Intervention Service, and what patients and carers valued was the expertise. So it wasn't particularly about a multidisciplinary team. It was about the fact that there was a clinical expert who understood breathlessness and could give them strategies to live with it. That's what was important.
That's great, thank you. And I can see Sharon's ready to speak, but I've just noticed in the comments, just to try and do this in order, Anne Meek Fox has made a comment about MND. I don't know if she wants to come online, or just want me to read it out. I can just read it. Oh yeah, perfect, you're here. No, I can just read it out then. So the resources look great, but just a comment, as an MND nurse, it'd be really lovely if MND was considered in development of these resources, as pretty much everyone with MND experienced breathlessness at some point. So maybe I'll start with you, Morag, this time, and then over to Matt.
Yeah, so I put a reply in the chat just to say we have got on the website, on the useful things page, there is a document that is a guide for clinicians on how to use the website if the person they're supporting is supporting someone with a non-cancer or non-COPD cause of their breathlessness. So do have a look at that. Whether or not it refers to MND or not, I can't off the top of my head remember, but it's certainly something, if that person wants to get in touch, we could have a look at making sure that it does. But completely agree. It's really hard to cover all of the possible causes of breathlessness, so we focused on the two main ones.
No, I think that's helpful. I think that's a helpful comment for us to consider going forward, because it really is an important group. Matt, did you want to add anything in from that point of view?
No, other than to agree and acknowledge the comment. It's a bit of a research and practice gap, because the services are often different, particularly for that patient group. In rehabilitation as well, there is a tendency to exclude that group from studies that they might benefit from. So it's a very helpful reminder and very healthy pushback.
And Irene, on your trial, did you include patients with MND, or if not, what?
In this trial, no, but
No,
I agree that it's a problem, and we've been looking at that in other ways. And obviously, people have tried, the non-invasive oxygen and so on. But I think that it's in a way you have to start with some groups. But I agree, it's a big problem, and I'd love to do more.
I think that's helpful, these discussions, then, to start thinking about the next things we can do. And so thank you for that comment. That was really helpful. And Sharon, thank you for being patient. We'll invite you in to ask your question or comment.
Good morning, everyone. Thank you. And what a treat on a Monday to have so much expertise. It's brilliant. Thank you so much for organising this. Couple of things. One just is from the hospice question around designing services. When we designed services in Birmingham, we did it with the acute respiratory team, and that did two things. It gave us a feed in, because they knew us and we built really good relationships with them, and then they would sit in on the breathlessness management. So the patients that were frightened of hospice, or what hospice meant, or all of the stigma that sat around that, knew that their team were part of that service provision. So that worked really well for us. My question is just around resources so really simple resources. So we know about concerns about health literacy in this area, and the discussion around leaflet overload. Does anybody know or is aware of like really simple video or pictorial resources that we could use for patients and carers?
Well, actually, yeah, you've got your hand up if you can.
Yeah, so that there are videos on the website which you could point carers to, and that was material that was included because carers themselves asked for it. They're very short; they're literally about a minute long. But yeah, that's probably the most that we've got for carers at the moment.
Matt or Irene, any other resources that you're aware of? Or?
So it's a good question, and we've started moving into developing infograms, infographics, and other types of resources. So we'll take a look at how much we've done and whether we can do some more based on this with infographics. We've recently done an infographic to just explain what palliative care is as well, because that's not well understood, which we've put on, and we've done a little video that's gone on YouTube and an infographic that goes with it. The other thing is to get these, I mean, I'd like your view in where is it most helpful for us to put these things when we've done them, because that's the other thing, is to make them accessible. So, how do we get people to access them and find them in a way? We put a number of things on the European Respiratory the European Lung Foundation website, because that's a patient-led group across Europe, and and they translate everything into different languages with us. So that's been very helpful. So we put a number of things there.
Yeah, do you want to come back on that, Sharon? Any comments?
Yeah.
Yeah.
It's a really good point, because we're developing something at the moment for hospital management of breathlessness. And I've been searching and searching, and I found the King sites, and I've been and the videos and the resources on there, but it needs a really good search, and I know what I'm looking for. And so we're going to look at putting QR codes on some short little resources, so little flip cards. But there's something about, and I sort of watching this, thinking about that if there was a centralized person-centered resource, so I don't know, something on YouTube or something on the I actually don't know, somewhere that, rather than health focused and health professional focused, is a site that is about breathlessness management, that is for people living with breathlessness. So maybe like the health, the Heart, British Heart Foundation sites are great, aren't they? And areas like that, maybe something on there. But yeah, it's how do we get this stuff? How do patients get this stuff really easily, and how do we make it so it feels accessible to them? I don't know the answer.
Okay, I think we're going to let Matt come in with a final comment there, and I'll just share some concluding remarks. Did you want to?
Yeah, you're right. There's a lot of wonderful stuff, but it's hidden or hard to find in the whole internet. And I think we should also just be like, we're making progress. I wanted to flag Sabrina Bajwa's work, who's particularly looking at people from different ethnicities and how they want to receive information about breathlessness management, but also being kind to ourselves. And we are like pioneering an example of a symptom-based approach to care and health and care services. And because of that, you know, the British the Asthma and Lung UK is a good but not the only place to have breathlessness resources. Same for British Heart Foundation, and same for Macmillan and some of the cancer organisations. So I think everywhere, and we're trying to cover the whole field, but importantly, we're still thinking in a trans-diagnostic way, and we're thinking across services and across professions. So we're good at that in palliative care, but we're also working in a system that wasn't designed, you know, in that way in the first place. So sharing our ideas, I think, is how we'll accelerate the progress.
Thank you, Matt. And thank you also. It's just a couple of final comments, just to say, first of all, to say thank you to our three presenters. It was absolutely fantastic. Each of work individually was fantastic, but I think what made it really amazing was that collective whole, and really feel like we've gone away. Now we're all going to change practice, change our slides for our medical students before next week, and it really is uplifting. And then there's always more things to do, so I think that's what's given food for thought for everyone about the next steps. Everything is going to be shared. I think people have suggested that we also share the links in the chat, which I think is an excellent idea, as well as the resources and the videos. Please, can you give us some feedback, not only about the presentation, but even more importantly, any ideas about you'd like for future topics? There's been lots of interest in these webinars, and so we're going to commit to having our next webinar by early February, and so we would like your engagement about what topics. We've got some ideas, but really it's over to you as well. That I think we're going to keep going with these webinars because they have proven to be of interest. So do let us know what you find helpful within these. So thank you again to our panelists, and thank you all for your participation and interest on a busy Monday morning for many of you, I know. So thank you all.